Good morning and welcome. Thank you so much for joining us on this early Thursday morning. We're here for the November edition of the CMN Virtual Collaboration Forums. I'd like to kick off this morning with a land acknowledgement. We would like to recognize that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory, and is a traditional meeting ground and home for many Indigenous peoples. Today, we're going to focus on stories from Kainai, First Nation, and Sioux Lookout community substance use programs. At the end of this session, participants will be able to reflect on community substance use approaches used by 2 Indigenous communities. They will be able to recognize the importance of culture in the community approach to substance use programs, and analyze and apply strategies to their own community substance use approach. Kathy, would you like to introduce yourself and give your disclosure, please?
Hi, everyone. It's Kathy Scrimshaw. I'm a family doc down in Pincher Creek, and I'm a part-time employee of the Alberta College of Family Physicians, working for the Collaborative Mentorship Network.
Thank you, Kathy. Another quick note, I've combined myself, Carrie McNabb, and Agatha Grachowski. We are your moderators and coordinators who do the behind the scenes work in the CMN, and we are paid employees of the Alberta College of Family Physicians. I'd also like to give another disclosure about the financial support for this program. We do receive financial support from the Alberta College of Family Physicians and through a Health Canada Substance Use and Addictions Program contribution. This CMN Virtual Collaboration Forum series are also certified for CME credit, so it is 1 credit per hour. We do 9 of these sessions per year, so just a note that we will not have a collaboration forum in December. The next one will be January 21st. We also take off July and August, so stay tuned for upcoming events and future topics. It's also important to note that there will be an attendance survey link in the chat log. So in order for us to issue your certificate of attendance, you get that credit. Please ensure that you enter your first name, last name, and email in that attendance survey. All right, again, it is very important for you to fill out your event evaluations. We hugely appreciate them. We usually typically use those as a needs assessment as well to see if there's any upcoming topic suggestions. So that helps point us in the right direction about what you would like to see at the next collaboration forum. We've also added a little incentive. So your name will be entered to win a $25 gift card as the prize. So please enter those going forward. All right, so we're going to dive in this morning. So we do have 2 presentations. We're going to start off with Dr. Esther Tailfeathers. So we're very excited to have her join us this morning. She's going to talk about bringing the spirit home, the Kainai Safe Withdrawal Management Site. So we're going to dive in. Esther's going to share a little bit with us. If you have any comments or questions, please post them in the chat log throughout. If we can't get to them during the presentation, then we'll definitely address them during that question and answer portion at the end. So again, please use that chat log. Agatha and I will moderate and get Esther to answer anything that you guys might have throughout the session. So also hoping to hear from Claudette Chase as the second portion of the morning's call. So we'll dive in there when we get there. So at this point in time, I'm going to turn things over to our next speaker, Dr. Esther Tailfeathers. Thank you for joining us this morning, Esther. Over to you.
Thank you. Thank you very much, Carrie, and thank you for the invite, Kathy. I'm going to just review a little bit of history of the opioid crisis on the Blood Reserve, and one of our favorite projects and very successful projects. So I'll just get started here. Next slide. Okay, so I have to do my disclosure. I'm Dr. Esther Tailfeathers, family physician for the Blood Tribe, but I also work for Alberta Health Services as the senior medical lead for their Indigenous health program. My relationships and interests, I do belong to Changing Horses non-for-profit volunteer, or it's a non-for-profit company, and we're we're developing small units or houses for homeless people here on our reserve. And I have no honorary or consulting fees. Okay, so this is Bringing the Spirit Home. This is a staff, all EMS staff that work at our safe withdrawal site. And they are all very hard workers and have done a lot of work. There's many, many EMTs and paramedics behind these three who are working there. Next slide. Okay, so the Blood Tribe fentanyl experience began way back in 2014, and I suspect earlier than that. But between 2014, 2015, around August to January, the Blood Tribe experienced at least 20 deaths due to fentanyl overdose. In late December 2014, our chief and council declared a state of emergency, and the community began to unite to strategize. One of the first things that we did in our strategy is introduce harm reduction. And the community was very torn on understanding what harm reduction was. We introduced naloxone and talked about the life-saving abilities of naloxone. And many of our older people who are abstinence-based thinking were saying, aren't we enabling them? And the only thing we could say is, you cannot enable a dead body. So people began to understand that we needed to save lives. So we are the first First Nations community in Canada to begin to teach our people to use naloxone. And then we had large distribution of naloxone to our community members, as well as huge blitzes or teaching sessions. So from March 2015 to June 2015, there were absolutely no deaths due to overdose on our reserve. So we know that that harm reduction step helped our people to save lives. The next steps that we have taken are to introduce opiate replacement therapy. And the initial one was buprenorphine naloxone, and most people will call it Suboxone, and it's known as that in our community. So we introduced clinics here, Dr. Susan Christensen in Laverne, myself in Standoff, and Cardston had a clinic in the hospital. And we began to see a reversal of the behavior and all of the consequences due to illicit opioids. So we saw a decrease in overdoses. We saw people being able to buy groceries and feed their children. And for the first Christmas ever in a long time, they were able to put up a Christmas tree and buy gifts for their children. So we know that young families were very happy with opiate replacement therapy. And since then, we've seen many return to school or get employment and resume productive lives. We also have initiated new treatment initiatives here on the reserve, and we work together with all of the entities, including the police, children's services, social services, to support those, to recognize and support those that are in active addiction or who are recovering, and finding ways to support them in the community. Next slide. So the underlying reasons for this crisis, many people will ask, why did it happen on the Blood Reserve like that? One is that it is happening across the province, but it was manifested and caught here on the Blood Reserve early. We still are dealing with it, but some of the underlying reasons are, number one, historic trauma, and the link between residential school and adverse childhood events, which I will discuss in the next slide. The second thing is social determinants, and one of the greatest social determinants for opioid use disorder is poverty. And we see that across our community, and you will see that across the province and country for First Nations and Indigenous people. Many are below the poverty line and have found ways to survive. The third thing is health service delivery, primary care. Many communities, many Indigenous communities across the province do not even have primary care or adequate primary care delivery in their communities, and they rely on outside communities for their primary care. As a result, and also because physicians are unaware, or also there's very little support for pain management other than prescribing opioids. So as a result of our health service delivery, we've overprescribed patients, and so we end up with people that are dependent on opioids. And as you know, a few years ago, the college had decided that we would address this, and instead of people addressing it in a proper manner, many patients were left without primary care physicians and without their prescriptions. And we think at this time it was a turning point from prescribed opioids to illicit opioids. Okay, next slide. The adverse childhood experience study that was done by Kaiser Permanente in California was able to take a look at the direct link between adverse childhood events or experiences and chronic illness and mental illness and addictions. So adverse childhood experiences were directly linked to residential school. And there are 10 points that they had picked to measure the adverse childhood experiences. And they were things like emotional abuse, physical abuse, sexual abuse, abandonment, and other major adverse childhood experiences. And most of the people that went to residential school could tick off almost all 10 of those experiences, at least 6 of them. And so what we see as a result of the trauma that those children experienced was a disruption in their neurodevelopment, a disruption in their social and emotional and cognitive development, creating impairment, and the adoption of health risk behaviors. And most of us physicians who have worked in rural emergency rooms recognize that many of the beginning of prescribing opiates happens with an MVA and a serious injury like a fractured ankle or a fractured arm. And that is a result of high risk health behaviors. Also, many of the patients that we see involved in domestic violence. So it goes on and on up till disease and disability and social problems. So we see a lot of people with diabetes, hypertension, chronic illness, and a lot of that is secondary to their adverse childhood experiences. And of course, early death. And we know in Alberta that the lifespan of First Nations is almost 12 years less than the average Albertan. And now with this COVID crisis, we're seeing doubling of deaths across the province to opioid overdose. Next slide. Some of the health effects of intergenerational trauma are increased suicide attempts and poor mental health status, a decline in social cohesion, effects in parenting and attachment styles. And you will see that's even getting, I would say it's getting worse, because we're seeing a lot more children going into the child welfare system and foster care. We're seeing an increase in addictions, and this is why we're here today. And the children may experience greater abuse, neglect, and household dysfunction, which increases their depressive symptoms. Next slide. I just briefly want to comment on this. There was a study done in Saskatoon by Lemstra and Neudorf, which showed that the most powerful social determinant in the city of Saskatoon was those that lived in poor neighborhoods versus those that lived in affluent neighborhoods, and that was directly linked to the health status of those. And we know that poverty is one of the greatest social determinants in all of the communities that we work in. Next slide. Okay, so our inpatient detox and intox support, as I mentioned earlier in this presentation, we had started with basic things like naloxone and then moving on to opiate replacement therapy with Suboxone, and we have now added methadone. And then we've increased our treatment supports in the community and worked with treatment centers across the province. So one of our biggest gaps was detox. We were finding that people were overdosing. They had their overdoses reversed. They were brought to the emergency room. They were assessed and then discharged from the emergency room only to go and seek it again. So many of us that work in the emergency rooms have seen people maybe 3 times in the same day after overdosing, throughout the day. So instead of that, we decided on building our own detox, where we would bring our patients who overdose directly to our detox. We call it Bringing the Spirit Home Safe Withdrawal Site. So it originally started from me volunteering at the treatment center about 2 Christmases ago, to actually getting support from the NDP government at that time. We were able to get support to open a 24-bed unit that was open 7 days a week, 24 hours a day. It's led by paramedics, EMS staff, and it's medically supervised by myself and 2 other physicians in the community. So we divert people from the ER to the safe withdrawal site. So instead of the ambulance bringing an overdosed patient to the emergency room, they bring them directly to detox and the safe withdrawal site. And in that safe withdrawal site, we observe the patients, and then we also help them out with supportive medication. And people who are in severe withdrawal, and many of you may have seen that, where we've seen a combination of people of withdrawal from opioids, crystal meth, and sometimes other substances. And people just can't be settled with at-home Ativan or light treatment. They need to be sedated through 12 to 24 hours of the worst part of their withdrawal. We often use Midaz, Halidol, and now with the new, we're not even really sure what the new ingredients are or the new poisons are in what we're seeing in the community, but we're thinking we're seeing bath salts, and we're seeing some really aberrant physical movement. So we've added ketamine, which helps relax those people and helps them to sleep through the first part of their withdrawal. We take directly from the ambulance, they bring them directly to there, or people are allowed to self-admit. So they walk up to the door and say, it's time for me to get detox. So we bring them in, and we are supposed to have 24 people in there, but we usually have like 31 to 32 people. We've been up to 51 people, where we're very, very crowded. We take people from across the province. So we have Indigenous people coming from even Fort Chip and the northern communities. We have a lot of people that come from our neighboring Bigani community. So it has grown and it is busting at the seams. Next slide, please. Okay, here it is. The patients are brought in by ambulance or are self-admits on a voluntary basis. They're supported through withdrawal with appropriate supports. And like I said, we use either, if it only needs Ativan, then we only go with Ativan. But we have a protocol for midazolam, Halidol, ketamine, support with fluids, and then of course the non-medical supports, which is listening to people and supporting them emotionally through the first few days of their withdrawal. They're offered to stay for 7 to 21 days, and that has gone as far as 3 months. We had one individual who was one of our first patients who was there for 1 year before he went into treatment. During their stay at the safe withdrawal site, we begin to access treatment centers. So our staff accesses treatment sites for them, and they're driven or transported directly from our safe withdrawal site to the treatment center that they get into. So there is less possibility for them to relapse in that time. Next slide. So this whole thing began with what we call the treatment table, and everybody calls their community organization something different, but ours was called the treatment table, and that began in 2014. We brought community members to all the initial meetings. Many of the members within our meetings included addiction specialists, mental health, social workers, treatment center people, elders, youth. We just brought in everybody to sit at a table and just talk out our situation and start looking for solutions. So we came up with a treatment pathway, and that would be from beginning, recognizing an addiction in a physician's office to people that are very vulnerable and in a bad state. So we've developed kind of a continuum of treatment care, and you'll hear that being said across the province, a continuum of care for treatment. We have done that locally, and we're filling the gaps that way. So this whole thing evolved into a draft plan that's called a Blood Tribe Addiction Framework, Bringing the Spirits Home. Next slide. Next slide. Okay, so our safe withdrawal site has brought our overdoses in the community down from 45 a month to 11 a month. Our crime rate is down. We have decreased ER visits to the Cardston emergency room and to the Lethbridge emergency room, and we have decreased hospital stays in our local hospital. So we think that this is very successful in terms of return of investment for our whole community, as well as the outside community in Alberta Health Services tertiary care. Next slide. So it's a work in progress. We're learning and adapting as we go. Our paramedics have learned a lot about addictions and the trauma that many of our people have gone through. So our paramedics have become very compassionate, and they've also become very tough. So we've really brought them along a learning pathway. Our medical staff, support staff, and elders also have learned a lot about managing behavioral challenges and family and social dynamics. What we have recognized is many of our patients learn addictive behavior as well, because they've had to survive and be able to feed their addiction. And so many behaviors are developed that weren't originally that person's character. So we're learning to manage behavioral challenges and recognize manipulation, recognize depression, and all of the other things that go along with the behavioral changes in people with active addictions, as well as those that are stabilized and not using but still have behavioral challenges. The Safe Withdrawal site has educational benefits to our community, to paramedics, and those with lived experience who are taking their experience to our schools and talking about what happens in the addictive course. And we also are taking youth in through Jordan's principles. So we've had multiple youth who have nowhere else to go, who have been on the streets and are actively addicted. So they are supported through Jordan's principle in our institution, or not institution, but within our Safe Withdrawal site. The other thing I'm very proud of is that we have taken in a number of pregnant women. We've supported them through their pregnancy, and one of our staff will go with them to the hospital for delivery, and so they will stay side by side with the pregnant mom until she delivers. And we have developed a small nursery room within our Safe Withdrawal site, so the mom may return from the hospital with the child and is supported by staff. And I know this sounds strange, but the other clients within our Safe Withdrawal site help with childcare, and we avoid child welfare apprehending the child, and we help the mother to support the mother to bond with the child and be able to learn childcare. So we think that that's a great part of our program. Okay, next slide. Any questions?
Hi, Esther. Thank you very much. It's Kathy. And in the chat, there was a question from Joseph. And he was he said, very interesting. He's wondering about the sedation protocols. If you guys could share those with the network, that would be great.
Okay, I don't have them with me. What I would
No
do,
problem. Yeah, send
yeah.
them to me and we can post them and send them on. Joseph, do you have any other questions? I think you can just unmute and ask.
No, I do not. Yeah, that was a very good presentation. I think that's the only question really I have. I would like to see what that actually looks like. It might be beneficial in some situations. Most of us don't. I have never done that before, but I know sometimes an inpatient, for patients that you don't know exactly what we're drawing from, it can be quite challenging to actually get them to stabilize quickly, even with a good loading dose of Suboxone. So, yeah, I'd like to see what that looks like. Thank you.
Okay. Maybe
Great.
Kathy could just pass that on by email, and then I'll see what I can do about what we can forward.
Yeah, that sounds great.
Mm-hmm.
And then we have another question from Kathy Unsworth. We know that individuals with FASD do not have great success in traditional treatment settings, but the prevalence of substance use is higher. We also know that polysubstance use is common in FASD population. Are you doing any screening for FASD when people come through the withdrawal site?
Yeah, we do screening for them. We recognize that they need more support. We recognize that there is a huge gap in Alberta in terms of treatment for FASD individuals as well as those with brain injury. So because many of our clients have experienced number of overdoses, it does cause some brain injury. And we're not sure, to what degree most of them are at, but we do have multiple people with either FASD or brain injury who do not fit into our traditional, I'm not saying Aboriginal or Indigenous traditional, I'm saying Alberta traditional treatment centers. There just doesn't seem to be a proper placement for them, and so they do not benefit from most of the treatment centers. So I think that's a gap that we as physicians in Alberta need to take a look at. I see a need for a dual diagnosis center for Indigenous patients because we do have a large number of those patients who are FASD or have some brain injury. Also, many who have severe PTSD or depression or any of the or mental illness that was prior to their use or developed during their use.
Yeah, I agree. That's a great point. We have a question actually from Claudette Chase, who is our other speaker, and she was asking about ketamine and the unforeseen mental health benefits. Have you noticed that if you're using ketamine and the new, or probably not so new, use of ketamine for PTSD and depression, etc.?
Well, we've noticed, like I said, we started using ketamine only if we needed it, only if the Midaz wasn't working. We've had a lot of learning experiences with sedation, and when we tried Halidol, we know that you can only max out Halidol to like 10 per day without having the extrapyramidal symptoms. But we have been experiencing a new I would say ingredient within the drugs that we're seeing here in southern Alberta, and we think that bath salts are included in what people are smoking or snorting, and it's creating real severe movement. Like you can tell the movement is not opioid related, and it's not meth related, so it has to be something else. And we initially started with low doses of midaz, and we found that we were going up to very high doses of midaz to be able to get them to rest and sleep. But it does seem to help in terms of helping them to settle after, but we don't use it long term.
Great, thank you. And we have a couple of comments in the chat that I just wanted to share with you. Drake, who is one of the nurses actually in Lethbridge, just commented, really sounds like it's going above and beyond just simple detox and ensuring clients get true help, not just acute sobriety, and very encouraging to hear. And I have to agree, some of my pregnant patients have gone through your program and it's been excellent. So I just want to a shout out to you. And then Laura Nixon, who works, I think at the Alex, Laura, she's finding the same with older people with severe substance dependence, brain injury, multifactorial, and difficulties finding suitable treatments. And again, that dual diagnosis of they don't fit into the standard sort of model that we have in Alberta. So again, some more movement for advocacy for that. So thank you so much for sharing the story. And I know my patients on Pekani have benefited hugely from that. And I hope that we can develop more of these type of community approaches.
Yeah. Thank you, Kathy. Thank you, everybody.
Thank you so much, Esther. And without further ado, we will go to our next speaker this morning, Claudette Chase. Thank you for joining us this morning, Claudette. Please feel free to unmute yourself and I'll turn things over to you.
I might just do a brief introduction. Claudette is a family doc who works at Sioux Lookout and has been working in Northern Ontario for a long time. She's also been, you may recognize her name from being on the national board of the Canadian College of Family Physicians, and she's active in the Society of Rural Physicians as well. So I just thought I'd do that brief introduction. Thanks, Claudette, for joining us.
Thank you. It's going to be hard for me to move on from Dr. Tailfeather's presentation because it was so rich and there's so much that is the same here. And will you be putting up my slides, or is that something I should be doing?
I've got you covered, Claudette. You just give me the word and I'll go to the next slide.
All right. Yeah, because, well, but I just wanted to say, you know, in terms of the adverse childhood events and the impact on both mental, emotional, spiritual, physical health, that is certainly very similar. One of the things that is not similar is, despite the hospital and Sioux Lookout being built with a four-party agreement between Indigenous organizations, provincial government, town government, and federal government, that mandated that there would be a detox there. We very briefly had an amazing 5-bed detox / gateway to treatment program. And I think it was open 2 years. And then a consultant from Toronto came up and said, this is not the way addictions treatment is being done. And you could do much more as an outpatient, which we didn't have an outpatient facility. So basically what that meant was it pretty much undermined any opportunity for people to go for detox and treatment when they were ready. So I'm very envious. And one of the questions I was going to ask is, can I send my patients to Alberta? But I know what non-insured would answer. Okay, I'm ready. So I have, I had an unrestricted grant. That's actually an old slide, and I think I'm well beyond, but I compulsively confess to any pharma contact I have. So there was an unrestricted grant to develop an online resource that was meant to really help families. This was probably 6 or 7 years ago. And other than that, nothing to declare. Next. So this is a map of the area where I've worked for most of the last 35 years. The big black star, the southernmost one, is showing you where Sioux Lookout is. And then the community I serve is one of the blue stars, sort of north of that. But basically the area where we work, we serve 23 fly-in remote First Nations, some who in years where climate change hasn't affected us have ice roads in the winter, but for the most part are fly-in only. Okay, next slide. So this is just the reality of where we work. When the programs were developed in our area, which started about 13 years ago, and I will get into the history, Health Canada was not wanting the nurses to be involved. So we have, well now I think it's 176 people, not all of whom get direct observed therapy, but many who do. And we, as the physicians or nurses, train lay people in the community who've been extremely brave and have taken on this hard work without the, you think of the training that most people would get who were working in a CHC or a place where there was a high percentage of people with addictions, on how to manage some of the behavioral issues, how to keep themselves and other clients safe. And these people have had none of that training. They just show up and do this work. And in the community that I serve, this was again 13 years ago, just by going door to door, which is not very scientific, these two women were able to get 400 people to endorse opiate dependency in a community of 1,250 people. We have a Hep C rate of about 1 in 100. It was rising sharply, but we did a tremendous amount of education, and the community agreed to having provision of safer kits that include stuff for cooking and snorting, and we try to give those out freely and encourage people to use them. But our new cases now, one of the things I'm realizing we're missing is the new teenagers who start using, that often they haven't had the education about not sharing snorting equipment. And so that's often who we see as our new Hep C cases. And I mentioned Health Canada has mandated that the nursing station is the only healthcare facility in the community, and their nurses don't do narcotic control. So some of the communities have had problems where the person who was charged with keeping track of Suboxone, which is a very powerful opiate, and I say Suboxone only because our communities have not taken to the generic, but I should say buprenorphine naloxone, but it's hard for my tongue to get around it this early. So the nurses aren't involved, so we have community members who are, again, doing the counts and keeping track of the medications and deciding when to send people back. And, you know, we had some very understandable challenges early on, because these are people who haven't been trained on what the federal narcotic law is. So often what they would do is if someone's meds didn't come in and somebody else had dropped off the program, they would say, well, we have extras. So we just shifted them. So, you know, we did a lot of education about there aren't actually any extras. If it's prescribed for one person, that's who has to get it. And if they don't get it, unfortunately, it has to go back to the pharmacy. Next slide, please. So the successes of these programs, and the community I served was the first one to start it. There were communities where as high as 75% of the adult population was addicted, and it was mainly OxyContin. And that was the drug of choice at the time. Now I find it's Percocets, and some communities have a big problem with hydromorphone and morphine. The community I serve, people have switched where initially people didn't like cocaine. And I think in fact this is just the world according to Claudette, it's not scientific. I think so many people had a trauma history, and so something that kind of revved them up wasn't appealing. And they were looking for the calm that they got from oxycodone. But now that the addiction behaviors have become so powerful and such a coping mechanism, I find cocaine is really rising in popularity. We are starting to see fentanyl contamination in marijuana, cocaine, so-called Percocets. We have not had the overdose rate that Alberta and Saskatchewan see, although we know from past experience that some of the hardest traumas and things that hit Indigenous communities in Canada tend to go west to east. So we kind of have been holding our breath and waiting. Thunder Bay itself, where many of our patients go for medical or counseling, actually has a much higher rate of overdose and fentanyl use. And so we have big concerns about people coming from the community who maybe were snorting 5 Percocets a day, and then all of a sudden they get hold of fentanyl, that the risk is very high. But I'm supposed to be talking about successes, not challenges. These programs that we have all been developed with the full participation of the community, and Chief and Council have had to approve them coming in. And so it's meant that there's been really broad education on addiction, particularly opiate addiction, and the brain changes that can occur. So all team members have had to increase their knowledge of opiate addiction. And I think of some of the people who've been with us since the beginning, how they could function now in any addiction program anywhere, having had no formal education, but just having had a world of experience. Our programs are impressive in that compared to a lot of urban addiction treatment programs, we have only using buprenorphine and naloxone, we have a greater than 90% retention rate. Several of the communities, there's been studies done to look at what the impact of having these programs are. And much as Dr. Tailfeathers mentioned, there's less theft and violence, there's increased participation in community activities, fewer children in care, there's higher vaccination rates, and so a lot of positives. Some of the things that I saw in the community that I serve, I remember after the first year it was running, I was asking people, you know, how are you finding it? What's going well? What are the challenges? And one of the loveliest stories for me was a couple who had actually been split and got back together once they were on treatment and got their children out of care. And I said, well, what's been different for you this year? And they said, we've been able to go out and get wood. And any of you who work with Indigenous people might know that that's way more than getting fuel for the fire. It's a whole day-long experience of the family going out together and making bush tea and reconnecting to things they did with their parents and their grandparents. And it's a real sign. It's something that gets them healthy physically, but also spiritually and emotionally. It's a lovely thing. There were people who hadn't been able to buy their kids Christmas presents in 5 years that were able to do that. Houses were completely bare of furniture. Those things all improved. There are support groups sort of within families. There have been outside counselors and workers that have been brought in with in some communities with great effect, where there's regular ongoing circles. In the community I serve, I as a white settler thought having some kind of program like NA would really help people, because I noticed how much isolation there is in the lives of people who've lived with addiction for a long time. And we several times brought people in and it hasn't taken off. And so I've realized that is me thinking this is what the community needs, not what the community has said they need. So what they are asking for and what they are trying to build right now is community-based treatment programs, so that people get more time out on the land, more time with elders, and also have Western counseling if that's something that they're interested in. Pregnant women are integrated right into the programs. but I again was envious because I think there's only one treatment center in Ontario that will accept pregnant women with opiate addiction. And we find most women are highly motivated. And in fact, one of the educational pieces we had to do was we found women were stopping as soon as they found out they were pregnant and then miscarrying. So we now do regular education. Don't stop, come see us. We will get you on treatment right away. And we have, I would say, maybe 1 in 100 women who will lapse during pregnancy. They're a very highly motivated group. We've definitely seen a decrease in the risk of bloodborne infections, and that's a wonderful thing. And just lots of individual stories of success. So next slide, please. And this is one I have full permission to share this photo, but I do love a chubby baby. But this young mom, this was her first pregnancy, and she was very concerned when she found out she was pregnant, and we had long talks about how to stay healthy and what to do. And she had this little munchkin and then went on to have 4 more boys. So she has her own little hockey team now, has moved to Thunder Bay, but I do bump into her occasionally, and I love seeing her with her gaggle of healthy boys. So next slide, please. So I certainly wouldn't have been able to do this without partnerships, because when I started supporting the community with this, actually many of my colleagues in my practice felt like it was really, like that it was dangerous and I shouldn't be doing it. But Dr. Mel Kahan was a firm supporter and mentor and helped me with dosing and protocols, and he and his colleagues have been ongoing supports for us. He actually also recruited physicians from Toronto, many of whom started partnering with the community and coming up to support the programs. And 12 years later are still connected to us. And one, in fact, who had been doing straight addictions has gone back to comprehensive family medicine as well as addictions. So they provided education and community clinical support. We've got a listserv just for this area where people can ask questions, and it's very helpful. And that mentorship has been ongoing. The CPSO initially, and for years, they reacted to this problem and agreed to help pay for these addiction doctors to get to a city of entry. So Thunder Bay, Winnipeg, or Sioux Lookout, and then Health Canada covered the rest of the travel into the communities. CAMH provided some training of frontline workers, and OTN provides telepsychiatry services, which at times has been helpful, but maybe what's more helpful now is that there is broad-ranging counseling available. And the communities, each community has developed their own program and has different rules. And some of it is that there's tremendous diversity. There are communities who really would prefer an abstinence-only program, but have begrudgingly accepted Suboxone because of high Hep C rates and other challenges. So the community I serve has the initial rules, and there hasn't been much change in this, was that no carries until you were down to 4 milligrams. The highest dose they were initially comfortable with people getting in community is 16. And we have had a few people who've transferred in at 24, 18, but they've all successfully weaned down to 16, which is a bit of I wouldn't have thought that would be the way things work. So it's interesting how, if we have different expectations, patients can meet them. But and so and if you go from one community to another, that can be completely different. There's another community where most people are initiated at 32 milligrams, for example. And the communities share and support each other and talk to each other about the experiences and how tiring it is, how hard it is to run one of these programs, but also how satisfying it is. Next slide. So the challenges is having Indigenous Services Canada not providing nurses. I mean, my understanding, having worked all these years within in Indigenous health, is that colonialism is alive and well, because it wouldn't have been rocket science to think that each program would have benefited from having a mental health and addictions trained nurse attached to it. And that has never happened. The fact that there was that somehow it was okay to say the nurses are too busy to take this on, but it would never occur to us to say, oh, they're too busy to take on diabetes care, which is in fact takes way more time and has way less satisfying results, I have to say. There's a lack of funding for real programming. So now the community I serve, which initially was doing a 21-day intake where people got lots of teaching around how to deal with cravings, lots of teaching around managing finances. It was a really broad, nice treatment program. Now all our efforts go into just making sure the meds get to the people who need them. Although, as I said, there is work being done to build this, which COVID kind of flattened, but to build a land-based treatment program. The complexity of the issues that were described so well in the previous presentation. So I see many people who were using drugs to put some barrier between themselves and incredibly painful, hard memories. And if we get them on a successful dose of buprenorphine, they're not stoned, they're not high, and they have to then deal with all those challenges, as well as the challenges of, say, the kids were in care and they're coming back and the kids are angry. We don't have effective family therapy at the community level. And the Child and Family Services, in fact, more kids are in care, or a higher percentage now than during the 60s scoop. And to me, that just is starting yet another generation who will be traumatized. Next slide, or is that, yeah. The challenges for patients, pregnant women, youth living with addictions. I mean, it's huge. It's huge. And for pregnant women, it's always the question, they're worried if they come forward that maybe their kids will be apprehended. But then if they don't come forward and get on treatment, then there's a higher risk of their kids being apprehended. Our hospital has yet to accept or to embrace the research that very clearly shows that children born with neonatal abstinence syndrome do better with their mothers. They do better rooming in. They need way less morphine, if any. And our hospital puts the babies, if their Finnegan score is high enough, into the NICU, and the mothers are discharged. So it disrupts breastfeeding, it disrupts bonding. It's hugely problematic. I don't feel like there is any kind of embracing of what would help keep those women and their babies healthy. The social determinants are largely unaltered. 75% unemployment, overcrowding. One thing COVID has really brought home to us is how poor the infrastructure is at the community level. And, for instance, our program runs in the public health room. So for 13 years, there hasn't been a public health room to do other programming because it is the only space available to do it. It doesn't, the waiting room is the same as that for the nursing station, and people are given numbers and called in. There's no privacy. So a lot of people are too proud to ever come on our program because they know there's just no way to keep that confidential. A lot of people who did well then really experienced strong social pressures to continue using, loneliness and recovery, coming to terms with the trauma and history, and the access to effective counseling, which is ironic, slightly better in not the Indian residential school counseling because people have to travel for that, but there has been a much more concerted effort to bring high-level counseling into the community during COVID. So Next, please. Is that it? Last slide. So I guess, oh, okay. Well, no, you can go back to the challenges on a personal level. Sorry. I think balancing safe practice with the need. How thinly can we spread ourselves? At one time, I was prescribing for a community that was most often visited by a nurse practitioner and her team who was doing treatment, and I only got there twice in 3 years, but they were desperate and there was no other option, and I just felt like that was a risk I had to take. Now nurse practitioners in Ontario can prescribe, so that's no longer necessary. The concurrent responsibility for comprehensive primary care. And I do think that I'm a family doctor, so I see people with chronic illness. Addiction is a chronic illness, so I should be doing it. But we don't have enough time or space in clinic to properly cover the needs. And we have never had a formal evaluation. We've had a couple of not very good evaluations that weren't useful, but so the community has made decisions to change key parts of the program based on what we feel is right, but we don't know what's right and what's most effective. And I would love to see an excellent evaluation done of our old program before we start this new one. So if there are pieces we really shouldn't be doing, we could drop them. Next slide. So I think this kind of maintenance programming in remote communities is feasible and effective, and that our doses tend to be low compared to most of the urban centers. For instance, by 6 months, most of the people in the community I serve are well maintained on 1 to 4 milligrams with no lapses. There are obviously exceptions to this. And of the clients we serve, all of them who've been on methadone said they're much more comfortable having Suboxone. So, and then something else that should be here is there was a survey done in my practice several years ago, and the consultant asked us to just answer quickly, what is the most satisfying part of our work? And about 99% of us, to our surprise, said it was working with people living with addictions, because you can have such a big impact. And so I would encourage others who aren't doing this to incorporate it in their practice. Okay.
Okay. So Claudette, thank you very much for that presentation. And I know that we're short of time. There's a few questions if people want to hang on there for a few minutes. From Emma McDonald there, she had a question with regard to the lower rates of overdose in remote communities. And she had heard other physicians in Northwest Ontario hypothesize that this may be due to various protective factors, such as a culture of sharing, using in groups. Is this something you see as a potential factor as well?
Yeah, the sharing is a cultural value, and it's one of the things that's impressed me from the beginning is someone may be going through horrible withdrawal and they get their hands on half of an oxy, but they'll call their cousin to come share with them. And so some of it is that, and some of it is that the cost, when there was still OxyContin available, the average price of a full 80 was $400. So for people who were on social assistance, they're getting about $900 a month. So there was no way they could afford it. And that's why people were selling things off. And there were horrible stories of young women going into the sex trade to support the habit. But yeah, so I think some of it is the cost. Some of it is the distance. They're just the getting the drugs into the community. There can be disruptions depending on weather and how strict a lot of communities search at the airport. So
right. And Janetta had asked a question, had a comment. This lack of health Canada nursing support is alarming, disparate with what is going on in the rest of the country. And I agree with, you know, it being a symptom of colonialism. What are the barriers, and are there opportunities to revisit given the syndemic rise in overdose? Can the rest of us help to advocate? How can we join sort of together nationally? Any advice there?
And this may be a sign of being old and tired, but we bring that up at every opportunity, every meeting with the ISC. There are lots of them that Anishinaabe Nation is having right now because of COVID. And we even had challenges getting public health nurses for COVID, which is, you know, it just is unreal. I appreciate that, and I will put some thought into it, and I will ask some of the other, you know, some of the nurse practitioner I know, what would be the most effective way to do that advocacy, because I think it is nothing short of criminal that the programs have had to develop. But on the other hand, the programs have developed and are strong now, and I think many of them would want to hire their own nurses rather than having a Health Canada nurse come in and tell them this is how it has to be done, if that makes sense. So that's why I think I will consult a bit more before I answered that.
No problem. And yeah, when you answer, we'll spread the word. We have a question from Rob Tangay. Knowing most data suggests retention rates to Suboxone of 30 to 50% at 1 year. Why do you think you have such high retention rates? And can you translate that to community practice, i.e. urban practices, small rural practices that aren't as isolated, especially with your knowledge of underlying trauma and return of symptoms when drug use stops?
I think if there could be programs that were run where doctors like the colleagues I'm lucky enough to work with were incorporated into those programs, but there was a high percentage of self-determination of Indigenous people serving those clients. I don't know that we would get as high a retention rate, because the isolation is definitely a helpful thing. But I think it could be much higher. It could be much higher, because there is a sense, one of the things we believe in, that my bias, having been to many meetings with a lot of urban practitioners, is their instinct is to give really high doses because you don't want the person to have any withdrawal or any cravings. Our patients have taught us they are so strong. They are so capable. And the community believes in their own people. And I think in a weird way that helps. So we are not, we have just a belief that there is a core of strength. And I have seen this in some of the most unlikely people to do well ever have dazzled me by, once they weren't sick anymore, they refound themselves. And I think that's a key component that can get forgotten, as we're all so terrified of overdose. I mean, you want to do whatever you can to prevent that, but to never forget that there is this strength.
Thank you. I think that's a great note to end on. Certainly the resilience and amazing, I guess, work that certainly my patients have done in this area, always humbles me. So I agree with you. I know we've gone over time. I really appreciate everyone hanging in there. Please fill out your evaluations. Any further questions and comments, please we'll connect you offline to Claudette and to Esther, and appreciate everyone joining us this morning. And thank you so much again, Claudette. And I know Esther had to go to a meeting, but thank you. Well,
it's such a treat to see familiar names, and I really appreciate the invitation. Take care, everyone.
Yeah, thank you.
Thank you, and have a great day, everyone. Talk soon.